Thank you for having me today. It's a pleasure to bring the health plan perspective on administrative data in study designs to benefit older adults. So I am the Senior Medical Director for Oncology and Genetics for United Healthcare. Just to provide some context for my presentation, United Healthcare is the largest commercial health plan in the country. We provide benefits for 28 million individuals through employer and individual plans. But as many of you may know, we also provide coverage for 12.5 million members who have Medicare Advantage or retiree health plans, Medigap plans. Through these plans, we provide healthcare benefits to 1 in 5 Medicare beneficiaries. And in addition, we serve 6 million members through our community and state plans, the partnerships that we have with state Medicaid plans. So I'm going to talk about the types of metrics that can be obtained from claims data, building off of what Dr. Schrag has already discussed for what's available from SEER Medicare data. So with health plan claims data, we get the types of, we're limited to the types of data that's very analogous to what's in the Medicare data. And that's somewhat limited in not having the types of clinical detail that you get from electronic health records or from the cancer registry. However, there is still a number of outcomes that can be assessed depending on the cancer type and the clinical scenario. So claims data often can be used to look at patterns of care, such as who gets radiation therapy following a diagnosis, the different cancer therapies and drugs that are used, duration of treatment, related procedures. It's a good source of data on comorbid conditions by looking at the diagnoses and other claims, as well as especially from pharmacy benefits, but also from some pharmacy claims, but also from the claims from the medical benefit, the drugs used to treat comorbid conditions. And there are specific outcomes that are frequently obtained from claims, whether they're being used in isolation or linked with other data. Time to next treatment is increasingly being used as a proxy for disease progression. It's a very good source of data for adverse events, especially things like hospitalizations and AD and emergency department visits. And it's a good source of information on the total cost of care, cancer-specific costs, drug costs, as well as patient out-of-pocket costs. The benefits of the claims data include that it provides real-world evidence. It is relatively timely compared to other data sources, although you do need to account for the duration of therapy and 3 months claims run out. So, we're always looking through the rearview mirror as new therapies come on the market or have new indications. And real world evidence takes time to develop just because you have to have patients get the treatments. And then as I mentioned at the outset, the real limitations are a lack of data on stage or disease biomarkers. I want to give a recent example, though, that they can be very useful. So this was a study that was done by Optum Labs at looking at new immunotherapies, new checkpoint inhibitors, looking at the cumulative occurrence of immune-related adverse events. And this was done, this was published now this year, but the data is from 2018 and 19. And we're able to see basically fairly quickly after the introduction and widespread adoption of checkpoint inhibitors, the cumulative incidence of adverse events, including hypophysitis and pneumonitis over time. And so it does, claims data do provide a very good way of looking at things like adverse events in therapies that are newly introduced in the market, that where we may have limited data from the clinical trials in a smaller population and maybe more selected population. There are different ways to augment claims data. So one way that we're starting to do is to use prior authorization data linked with claims data. So with prior authorization, typically we require the clinicians requesting a therapy to provide information on stage, histology, line of therapy, and biomarkers. And so while it's not validated the way registry data is and is not as clinically complete as electronic healthcare record data, it does provide a source of clinical data that can be linked with biomarkers linked with claims data that can provide additional insight on, and then more so than claims data by itself. So it's a useful source of information, or it augments the validity, the information that we get from claims by itself. Another exciting source of data that I want to highlight that's coming later this year, this represents an effort by Lynn Pebernathy at the National Cancer Institute and SEER, and Joe Hank at Optum Labs. They have been really focused on driving this collaboration over several years. And this will have linked data, registry data linked from SEER with United Healthcare claims data supported by Optum Labs. And so researchers will be able to obtain this data through Optum Labs. It's de-identified and can't be relinked to other data sources, but in and of itself, it provides a commercial claims registry that's analogous to SEER Medicare, being SEER health, commercial health plan data, which again includes those members with Medicare Advantage, as I mentioned before. And I know that SEER has other partnerships that they're working on with other health plans to obtain this data on more patients as well. I wanted to share how we've used the the claims data augmented with our prior authorization data to look at additional outcomes for cancer treatment regimens that you don't usually get from the clinical trial data. So this is, on the left is abstracted data from clinical trials, and you can see this is for colorectal, or actually I think these are pancreatic cancer regimens. So you can see for FOLFIRINOX, overall survival of 11 months and progression-free survival of 6.4 months, reported in the trial by Conroy et al. The toxicity is reported by that clinical trial. And then on the right hand, we see that data augmented with real-world evidence data, the all-cause inpatient stays during chemotherapy with this regimen, duration of therapy being 85 days, and then the total cost of care of $87,971 on average, with a pretty wide standard deviation. So this is the way that we've, we have been using our claims and prior authorization augmented data to supplement clinical trial data as we look to create cancer treatment pathways. So I think this provides an example of how this data can not supplant, but supplement the data that we and insights that we get from clinical trials. So this data is, as I mentioned, is we look at this real world evidence supplementing the clinical trial data as we create our cancer treatment pathways. So in our program, our cancer guidance program, we first look at whether or not a cancer treatment regimen is recommended by NCCN, and any of those treatments would meet our coverage criteria. But in addition, we look using an evidence-based medicine process, looking at the evidence from the clinical trials supplemented with real-world evidence to determine which regimens are the most efficacious, have the best toxicity profiles, and are most cost-effective. And so the hospitalization data and cost data is very relevant at that point. So this is just an example of how this kind of real-world evidence and additional data sources is used by health plans like United Healthcare. So in summary, I'm looking forward to the discussion where I imagine we'll get into some more detailed questions. Health plan data can enhance the evidence obtained from clinical trials on the benefits of cancer therapy in older adults. Linkages with cancer registry data and prior authorization data can be used to obtain clinical information, including stage, histology, biomarkers, and line of therapy, supplementing administrative claims data, linked prior authorization and claims data available to academic research partners through collaborations with Optum Labs and to industry partners through Optum Life Sciences. UHC claims and SEER data linkage is in process and should be available later this year. And real-world evidence provides information on additional outcomes typically not reported in clinical trials. And thank you for your attention.